Cheers.
Cheers.
Welcome to Coffee and Childbirth. I'm Dr. Rhee. I'm a chiropractic doctor, and I exclusively see women and children. And I always forget that it's where women and children thrive.
There we go. You didn't forget. You knew.
And this is Maple. What did I call her? The Chiro canine.
The Chiro's so cute.
Yeah,
I really
the Chiro
like that.
canine.
It's the cutest dog name I've heard in a while. I'm not really a dog fan, so it's the cutest phrase.
I appreciate that.
Yeah.
Thank you very much.
I'm Dr. Kelsey. I am a physical therapist by trade, and I help moms and babies in their homes. I don't have an animal at my home or on my person right now. So
correct. But you have two little humans.
I have two little human animals. Yeah.
I mean, they're technically animals.
They're technically
humans.
We're
are
all mammals together.
Yes, we are all mammals. We're just special.
Yeah. And we are going to talk about, which I feel like this is, I definitely learned from watching the episode you did with Dr. Mary Martin.
Yeah.
We'll talk about gestational diabetes and a little bit of like how we fit into that as providers. And maybe I think the next one we'll just do a mini case study of like, history factors that could have contributed to having it, but I didn't end up having it.
Yeah.
So tell me.
Yeah. Well, okay.
So tell me like when you explain gestational diabetes to a mom and she's just heard maybe horror stories or she's nervous like her mom had it or her aunt had it. How do you explain like what it is to an average person like myself?
I did tell them it has a lot to do with sugar in their blood and how you're metabolizing the sugar in your blood. I think for most patients, they know what diabetes is, right? So I go, well, the only difference is that gestational diabetes happens when you are obviously pregnant, but it can also occur again postpartum, which was cool that Dr. Martin did bring that up again. Sometimes I do forget myself to bring that up, because the chances of you having diabetes again, even postpartum, and when we say postpartum, it could be 6 months or it could be a year, it could be like 5 years, right?
Yeah.
It does increase, but you do forget about it, right?
Totally.
You do forget about it until years later. So, but I do, for me, even like as a perimenopause stage that I'm in, like my blood work the last year or so with my insulin, it's just been like all over the place.
Yeah.
But so in my head, I was like, well, I'm not pregnant. I've never had this issue my whole life.
Yeah.
I don't need
hormonal
a ton of
changes.
Yeah,
though.
but hormonal changes.
Yep.
And we're not just talking reproductive hormones, but cortisol was like a huge part. And the more I dove into it, I realized there is definitely, it's a mirror that we have to kind of like think of what's happening when we are pregnant, and especially if you're young. You really don't think about diabetes when you're young. The younger you are, the less chance of that happening. So when I have patients who are like 40 and they're getting pregnant, I'm like, it's definitely a conversation because we're already at a point where cortisol's off.
Yep. The perimenopausal cascade is beginning, or even just depending on your family history. It's just like, So I was talking to a client about that the other day, just like the challenges. It's not that you shouldn't necessarily have a baby at that time of your life, but I think that there's a lot that goes ignored when people are like, and I don't even think it's saying, oh, that means it's a geriatric pregnancy. I think it's just understanding if we move the timeline into a different season, then you not only are coming off postpartum like directly into menopause or coming off postpartum directly into perimenopause.
100%.
So that can feel, just for people to not feel like you're going crazy.
Right.
It's like, think about where you are. That support is hard. So when it comes to so diabetes is more commonly talked about. The difference is it's happening during the time that you're pregnant or you're in gestation. And also the fact that there's so many hormone drivers because of 100%. Pregnancy. And so then that affecting the blood sugar numbers.
Right. A big factor of it as well, people only think about it as just a dietary thing as well, which is true. It is a big part of it.
Yeah.
But that, I think, in my opinion, has a bigger part of it for an older population. They're pregnant, right?
Yeah.
We just don't metabolize our carbs and proteins and everything, sugars, the same ways as our metabolism was when we were 20, 25 years old.
That's usually the most frustrating part.
Correct.
About that process.
Correct. And when I did some more research after that conversation with Dr. Martin, I mean, it can be as early as the age of 25. That totally shifts. So you're like 25, that's so young.
You're like, I'm not even 30 yet.
Correct. But no, at 25, you can definitely, that shift can happen.
Yeah.
Another factor that I looked into after having that conversation, because I was also not just listening to Dr. Martin about for my pregnant moms, but I was listening to it more with the mind of like my perimenopause moms as well, right? And for me, with what I'm going through, and I've definitely gained weight the last like few years, more than what I'm used to having on my body. But I thought, my eating is still pretty clean. I work out like crazy still, and I have to really shift all that. And what I realized, like, okay, does how much of the genetics have something to do with it as well, right? Like, what is your baseline with your genetics, right?
Yeah, because it puts you in a position of maybe you're in the higher normal.
Yeah.
And so then if there's any other lifestyle things that will push you over the edge into diagnostically specific or significant.
Yeah.
So like you said, the changes of like, what is even working? What is exercise? What does that mean in that time period?
Yeah.
What is like your normal prenatally or when you're thinking about fertility, and how does, like, if you also are having, if exercise is a factor. So we talked about dietary. If dietary, we know, is something that is harder to change, but it's not necessarily like associated with pain. Movement and exercise, if you are in pain during your pregnancy.
Oh yeah, that's so
then
tough.
that really is way tougher as you're sequentially going through that to move, to even keep yourself in a range that's typical. And so that is where, like, as far as our, services and how we are as providers, if you're seeing someone like Dr. Mary Martin and she's saying, okay, you're kind of on the edge here. Good thing we caught this a little bit early so you're aware.
Right.
Okay, eating changes seem like no problem for you, but you're telling me your hip hurts. You're telling me your back hurts. You're telling me you can't lift your toddler right now because of X, Y, Z. Then it's like, okay, that still is part that we would need to be able to help you with so that you can just maintain that function.
One of the things that she also mentioned is like, I as a holistic practitioner, and I look at, a lot of my patients will bring me blood work to like have them looked at as a second opinion. And, the way I focused it was like, okay, glucose and insulin was like a big thing. It was a great reminder. Like, well, those are like a snapshot, of time.
Yeah.
We really should look at all three. The A1C is also very, very important because that just gives you that average time that is a look at like the last like few months of what's been going on with your body. The longer term. So I think that's really important to look at as well. But going back to the genetic part of it, I did some more research on the genetic because I was like, what does that exactly mean? Does it mean that you just have that DNA is going to like turnkey it for a diabetes in your system?
Make it more susceptible.
Yeah, but it's not actually. Okay. So the way when I was looking into that, it looked like it wasn't so much, that there's this gene in your DNA that's going to make you have more of chance of having diabetes. It wasn't really so much of that. It's the ethnicity background of the DNA is really more important because it's really your body type. So you're the number, and this kind of surprised me. I am not Southeastern.
Okay, so you are
Asian,
Korean.
but I'm Korean, which is Eastern Asian, right? East Asian, right? Whereas the Southwest Asians are the number one in diabetes. And I was like, wow. In my head, I thought it was going to be Hispanic. In my head, I thought it was going to be Hispanic.
Okay.
Because I don't associate with Asians as much with diabetes. But in my head, I was like, oh, no, I was associating the East Asians as like lower end diabetes.
Which would be, so East Asian, like you were saying, Korea. Would
Japan,
that be like Japan? Chinese. Okay.
Those are the East Asians. Now,
and then Southeast is going to be.
Yeah. So then it's going to be, Southwest. Okay, so I'm
going this way.
It's a Southwest Asian, Southeast Asian, sorry, would be all the Polynesians.
That's why I was like,
you.
Yep.
And then it would be also the Indians.
Okay.
Yes. So Indians, Filipinos.
Yep.
Right.
Yep.
A little bit of like Vietnamese is like, it's a little different because their diet is significantly different than the Filipinos.
Right. Even though they're geographically very close. Yeah. If you just look it up, Google or whatever.
Right. Because you can tell that when you look at the Vietnamese population, they're very different looking compared to even Thailand, and also
like
Philippines. Yes.
Kind of thing. So to your point, which is funny because when we were talking before this, I even had said to you of like, I knew going into pregnancy, my dad is Samoan, my mom is Caucasian.
Is he full Samoan?
He's full.
Okay.
So I knew I had at least 50% of my genetics working.
Okay. And
not
your mom
in my
was
favor.
What you said?
Caucasian. German.
Okay.
Dutch.
Gotcha.
But there's some obesity on that side regardless. So not necessarily, you know, the top number one, but if I'm saying 50% from the top number one potential, and then maybe just familially, that's going to elevate that. Yeah. So, and also I was a 9-pound baby.
I was a 9-pound baby too.
So
we were both 9-pound.
Yeah, we were big, healthy, ready for the world. What else? So yeah, you're right. It's interesting to know. And that was just something that I knew just from like growing up and just seeing like different body types. And also most of the time the feedback from people to me would be like, oh, you don't look Samoan because you're not big enough.
Gotcha.
So that was pretty ingrained early on, just in like the socialization, had nothing to do with medical,
of what it looked like.
Knowledge or anything. So that type of information, like fertility wise, understanding, you know, my husband who I had my babies with is like European.
With other people?
No, I'm saying that like the person who contributed those other DNA and those genetics,
the mixture of it. Yeah,
he was like European, you know, not in that top. It wasn't like it was another Polynesian person, right? Which I think then would have like really upped the chances for them for the kids.
So it was like Southeast Asians, then it was like Africans. No, I'm sorry, it was Hispanics, and then it was African. They were the top three. Yeah. And then I dove even deeper. Okay. I said, what part of that gene? So this is like my brain just nerd brain
epigenetics type.
Why is that happening in those genomes? And it really it boiled down to muscle mass and fat content of like body composition. Yeah. So like Southeastern women, East Asian women they don't develop as much muscle tone relative to ratio to fat tissue.
And it's interesting because, and this is a whole other question of that, but it's interesting because if I were to, and this is again a personal account, so it's not necessarily anything based off of research, but it's like, I know if I'm going to change my body composition at all, it's going to be developing muscle before anything else. If that makes any sense. Like mesomorph is going to be what I'm going to trend towards if I put in the effort. With dietary and lifting things, that's way easier for me than it is for me to go ecto or anything like that.
Can we tell the audience what that is a little bit?
So like mesomorph being more muscle based, I guess is how I explain it to people. Of like
M for muscle.
Yeah, M for muscle is like I can bulk. Yeah. But I'm not going to easily be able to lean. So ecto, I think of like ballet dancers, like super lean, it's like super lean, gazelle, long, skinny. Yeah. And then I think endo is just, I can't remember if endo was like average or more towards fat.
I think it was more, or not. I think it was adipose? More, adipose, more adipose.
So
just this is we're talking about body
composition, but you know, those types of things contributing to like how your muscles are consuming the blood sugar. This is all very like basic. Don't come at me for this, but you know, if you're explaining it to like that's kind of why knowing infertility, I'll be honest, I did not have my blood work done when I was like, let's have a baby. I did not. But making choices based on if I'm going to do workouts that are going to support just what my natural propensity is. I'm not going to be afraid of lifting weights. I'm going to try to strength train because I know that just is going to benefit me with how I'm processing blood sugars. Right. So that kind of stuff, obviously having blood work in the fertility phase would be so helpful for that knowledge of that, which she kind of talked about. I think she said, what was it? You said A1C and fasting insulin.
Fasting insulin. And then glucose is like literally just like a snapshot, like how much actual sugar there is in your bloodstream in the moment that you have drawn
which again is very time dependent. It's like the picture on Instagram of my child when they're so happy. 2 seconds later, or I turn the sound off and I don't share the sound. I put a song over it because they're yelling and I'm yelling or whatever the situation.
So, and then insulin is the actual hormone that metabolizes the glucose, which is the sugar, right? And how we
want that to be happening. Like Pac-Man style.
Correct. It's like actually binding into it and then taking it and saying, let's put it somewhere, right, to use or to store. But if you have too much insulin in your bloodstream, that means it's not doing its job.
Because once it does its job, it dies.
It just goes away.
Yeah,
so it's like metabolizes and goes away.
Right. So if it's just free floating, then it's like you're not working, you're not being used. So then it's just, and that's what causes some of those symptoms that we would associate with that. Which, interestingly enough, that was another thing that she, reminded us or people watching as far as preventative. If you're like, oh, I'm watching for symptoms of diabetes, and then I started noticing symptoms. It's actually probably already in full effect. And so it's not too late, but the decisions that we have to make, not me, but as your physician or whatever, if we're prescribing medication, it may, or something like that, it may go beyond a dietary change or a physical.
I think all of it is important, of course, right? And it also depends, like, so when we're talking like prevention as well, like if I have a young woman who's thinking about getting pregnant, right? Versus a mom who is coming to me at 20 weeks into pregnancy, the approach is going to be different at that point, right? Like what we're going to be doing and the prognosis of that, even if they're both 25 years old, right?
Because we're just going to take the test at 20 weeks and we're just going to take the test
and see what happens. Right, exactly. So I think, and then versus, a mom who's 40 and wants now thinking about getting pregnant, right, it's going to be very different.
Or maybe they had gestational diabetes for their first child and they're going to have a second child, and their physician didn't say, hey, let's try to track this in between it all. And then they're like, I'm scared I'm going to have that happen again. And it's like, oh, well, we can at least get a baseline for what it is. The other interesting thing she said that you just talked about in that episode was the differences in your numbers. So like white coat.
Oh, yeah. You mentioned that before.
Yeah, right. Which I thought was really interesting. Like the white coat effect. Most people, I feel like, know that for blood pressure.
I would say,
or more common.
I wouldn't say most people. I would say like, people do mention, I always get nervous when I get, if the people, they've noticed the trend in the past, then they do know that is the reason why their blood pressure is measured way higher in the doctor's office. Even with me as a chiropractor. So in my old office, every single new patient had their weight measured. I had a body composition machine. I had a blood pressure and a heart rate. They were all the vitals were checked before they saw me. But I also had 5 staff, so they were able to do all that stuff. And so I would have data.
And your turnover was, or the numbers that you were seeing was also different then. But you're right. So if you had it tested at all, then you're like kind of noticing, like, or my heart rate is like more elevated.
I think a person who's in their 30s and 40s and they've been to doctors enough, they're like, oh yeah, now like those people know that their blood pressure, if those are the type of people, they already know by then. They're like, oh yeah, it's always elevated when I go to our doctors.
And hopefully we're trying to breathe and get that, like, hopefully we don't just like go in and be like, I'm off the rails, I'm terrified. Like, I have to say that. Can we
I think it's also the environment, right? Because I've had patients tell me, and the reason why we're talking about the white coat, is because Dr. Martin was talking about how that affects the insulin number as well, or was it glucose or insulin that she said? Or do you remember?
I don't remember.
Okay. But it affects it.
But it affects it.
Yeah. And that makes
whatever
sense.
You take at home, is there a difference between what levels? So would it be your glucose?
Say that one more
Whichever
time.
one you would take at home, because she was talking about like.
Oh, that will be at home. Glucose. Yeah, glucose
so
is the
probably
one at home.
Glucose.
Yeah. So that can be elevated. I'm going to say, I thought maybe it might be more insulin. The reason I say that is because it's a huge correlation between cortisol and insulin.
Okay.
Right.
So that sounds
when your
accurate.
Cortisol is high, or I wouldn't say high, but it gets kicked up a little bit because you're in a more.
They're in tandem.
Oh my gosh, I'm in the doctor's office.
Yes, the adrenaline.
Yeah, the adrenaline. Right. It affects it a little bit, and so that would affect there's a correlation between a cortisol behavior versus also the insulin behavior as well. So I would say like it would make sense if their heart rate is going up. That means your adrenaline is going up, and then it might be affecting your cortisol, which also can affect your insulin as well, right?
Yes.
So that was a really great point that she made, which I didn't even think about at that point until she mentioned that as well. So that was a
and I was
point.
like, I didn't know that until I saw her say it, and I was like, oh, that makes way more sense. Why, if you're noticing that, you can monitor it at home, just so you have a little bit of an understanding. If you're like, I don't necessarily feel like there's a difference here, or if there is a big difference.
Right.
And I did go, in our personal conversation, I did go a little ham on my response to that. But if you're noticing a difference between your home values and your clinical values in your session appointment, understand that there is some support that you can go through if you're really like, I'm terrified of what the doctor is going to say, or if I'm really stressed out about this drink, which I'm sorry,
the gooey juice.
You can come at me for this, but it's not that bad. I have done it twice, and I did not elevate my number. So, just for people to feel like, it's just a test.
Yeah.
It's okay.
Yeah.
It's just a test.
I mean,
especially if your numbers are not, if they're at home, they're good.
Yeah.
Then you should be confident. That,
exactly. And that's what I was going to say. And so I can think of a case right now, just recently too. She had been doing the finger prick test at home, but every time she goes to her high risk visit,
because and high risk is not fun. Who wants to go to a high risk?
Yep. And so they kept saying to her, oh yeah, because of this and this and this and these numbers, and it's also, we had these numbers back when you were just starting out being pregnant. Because of that, we're just gonna like basically put you on the list of just like high probability of C-section. But she's like, but I've been feeling so good at home. Like my numbers are great at home. My blood pressure is great. Everything is great. And she comes in and then she asked me, Dr. Rhee, do you think that's a valid point that I should just be on that C-section? And I said, no. I said, don't you even let them make you feel like that is a possible. You've been doing fantastic. She's 39 and a half weeks now. And she's doing great. She's doing fantastic.
It's like, can we just call it extra love instead of high risk?
It really changes the perspective,
we're
right?
Just giving you more information. We're just giving you some more resources. Because
how do we change that? That's not going to, high risk, even just the word high risk, it's going to totally change the perspective of the mother
in the world.
It just gives them so much more anxiety, which really changes the quality of the pregnancy. I had another mom, yesterday, she was bawling out in her eyes because she was just like so upset that she never got to enjoy both of her pregnancy. Because of fear. All the fears that she had, they just kept putting more fears and more fears and more fears. And she's already a very, high anxiety person to begin with. So it was not adding onto her situation. But she still had like great birth, and eventually, so she's like, I wish I just like had more confidence in my birth, and I wish I would have had not listened to all the fear mongering that she felt like she had during that. There's good balance, of course.
You have to watch out for certain things, I guess. But funny enough, that kind of like dovetails into that person would be really great for hypnobirthing, because they need to be able to practice all of those tweaks, the awareness, but not the sinking into that feeling, the neutrality to that. So anyways, yes. So with like your numbers, kind of judge what your numbers are at home. It doesn't hurt to have information that you're giving them as well. You can ultimately make the decision. I do feel like she had said, even taking blood work after. So we talked about like prenatally, if you're aware, as in fertility, if you're thinking about that, blood work is helpful for you. And then she was saying even like if you had gestational diabetes and then postpartum, like 6 to 12 months, up to 5 years of monitoring it, not like every day, but taking your values at 6 to 12, so twice a year.
Even if it's once
a year,
just annual, just have a much comprehensive annual exam and
slides at all, or if anything's happening there. Because she was saying it was 1 in 2, so 50% of people who have had that during pregnancy will likely have that in postpartum. So, you know, the more you know on those things, but it was definitely like, what's it called? Brought more awareness to the topic. That was great and more helpful for me to like kind of answer some things informatively, obviously referring to the right person, but some of that like processing with people. Yeah. Because when you first hear something in a session, in a visit, it can be really intimidating. And if you don't know what they're talking about, or they just use medical language and they're not giving you analogies, you're kind of screwed in your mental space. I think that relationship that you have with your doctor is so important too. And then the vibe that they have in that office, right? Yeah. Like, I think if the vibe is very very clinical feeling, then moms are probably going to have more kind of fear or anxiety in it. And then, you know, I've had, you know, it's interesting because like even my office in LA was like a typical chiropractic office, but I tried my best to kind of have a more inviting, you know, vibes, you know, and energy. And then I've had few patients from LA drive out to see me here in Las Vegas, and they were like, this is so different. And they're like, this is I thought your office was pretty inviting and intimate in LA. Yeah. Like, this is super intimate. Yeah. You know? Yeah. And so that made me think about, you know, that environment that you create for your patient as well is so important. That it really is. Yeah. It really is. And I mean, I bring that, but it's hard sometimes because then, you know, in someone's home, it may not be the same level of relaxation. So it's like, you don't think so? Where I would think that they are more relaxed. No, sorry, they might be, but sometimes there's a lot going on. Oh, I see. Their house may not be as clean as they want it to be, which none of these things I care about. Right? Yeah. But that's the nature of like the good and the bad of you being comfortable in your home. And that's why sometimes people want to come into a clinic because they're like, I just need to get out of here. I just need to leave my home. I just need to leave my home for a minute. And so it just depends on where you are in your space. But anyways, that was a really good, I feel like I learned a lot. I think that will be helpful for women to kind of demystify some of those things that come up a lot. And we'll see you guys on the next one. Absolutely. Okay. Well, cheers on the way out. Yeah. Cheers again. Cheers.